The pre-hospital environment is inherently chaotic. When a clinician arrives on a scene, their immediate clinical instinct is to protect the patient from harm. However, that instinct immediately intersects with the patient's legal autonomy. In medical practice, there is a foundational legal axiom. Adult patients are legally presumed capable of making their own medical decisions. Unless there is explicit, objective evidence to the contrary, their choices dictate the course of care. A pervasive misconception exists regarding how that capacity is verified. The ability of a patient to answer basic orienting questions, stating their name, the current location, and the date, does not automatically equate to legal decision-making capacity. Capacity is a dynamic threshold. It fluctuates based on the exact parameters of the specific decision being made at a particular moment in time. A patient might possess the cognitive processing power to make a low-risk decision, such as accepting an ice pack or a bandage. That same patient, in the same moment, may lack the sophisticated reasoning required to refuse transport when experiencing a high-risk, potentially lethal cardiac event. Paramedics are required to objectively measure a patient's legal right to refuse care. This measurement becomes critical when an underlying neurophysiological issue is actively compromising the patient's ability to reason. Short-term legal incapacity is rarely arbitrary. It is usually driven by measurable physical disruptions in the architecture of the brain. To evaluate this, clinicians apply a two-stage test. The first step requires identifying if there is an active impairment or disturbance in the functioning of the mind or brain. In emergency medicine, these physiological culprits are frequent and varied. A lack of oxygen from hypoxia, severe acute pain, blunt head trauma, and acute delirium all actively interfere with neural processing. During a stroke, an ischemic core spreads through brain tissue. This creates localized physical damage that aggressively disrupts the global cognitive reasoning required to evaluate a care plan. Intoxication creates a similar blockade. High levels of alcohol or drugs chemically suppress neural receptors, effectively blocking the brain's ability to logically process long-term consequences. Even a drop in blood sugar triggers neuroglycopenic disruption, physically starving the neural network of the glucose required for complex logic. Once an impairment is identified, the clinician applies the second step of the test. They must determine if the specific physical impairment prevents the patient from understanding, retaining, weighing information, or communicating a distinct choice. Poor judgment is not a pathology. A patient cannot be doomed legally incapable simply because they make an unwise decision or because they disagree with a professional medical recommendation. Identifying a precise underlying physiological insult is the mandatory prerequisite before any clinician has the legal authority to override a patient's autonomy. When an adult patient refuses care, paramedics utilize the ACDC mnemonic. This provides a standardized framework to legally validate an informed refusal. This presentation slide outlines the parameters of capacity and informed consent. The definition of capacity hinges on the patient's ability to understand the provided information and make a decision based upon it. The text specifically highlights common pitfalls, instructing clinicians to watch for intoxication, post-ictal states, and cognitive delays that mask true understanding. The process must also be informed. The clinician has a strict legal obligation to disclose all reasonably foreseeable consequences, risks, and benefits, communicating them entirely in lay terms the patient can comprehend. The capacity requirement goes beyond simple acknowledgement. The patient must demonstrate they are actively using and weighing the disclosed information to form a rational thought process. Clinicians must separate physiological impairment from environmental friction. Emotional stress, severe language barriers, or distinct cultural differences can mimic cognitive incapacity. Paramedics must attempt to resolve these barriers, often by securing a translator, before declaring a lack of capacity. There are specific high-risk clinical circumstances that automatically preclude a clinician from accepting a refusal of care. Active suicidal ideation or extreme incapacitating intoxication immediately invalidate the patient's right to refuse transport. A legally valid refusal requires the patient to explicitly process and acknowledge the medical risks through the specific criteria of the ACDC framework. The rules governing autonomy adjust significantly for pediatric patients. Under British Columbia law, a minor is defined as any individual under the age of 19. The baseline rule is straightforward. For standard minors, informed consent for medical treatment or the refusal of that treatment must be obtained from a parent or legal guardian. However, the BC Infants Act contains a specific exception. It allows an individual designated as a mature minor to make independent healthcare decisions, regardless of their chronological age. There is no fixed age threshold for this status. Instead, the law relies entirely on the paramedic's clinical judgment regarding the patient's physical, mental, and emotional development. To grant mature minor status, paramedics look for explicit traits. These include a demonstrated ability to make independent decisions, economic independence, living apart from parents, and the intellectual capacity to fully weigh the risks and benefits of a care plan. Once a patient meets these criteria, the legal rule is absolute. A mature minor's decision to give or withhold consent cannot be overridden by their parents or guardians. An emergency exception remains in place for standard minors. If delaying emergency care to locate a parent would cause significant harm to the patient, the paramedic may provide immediate treatment under the principle of implied consent. When evaluating pediatric patients in British Columbia, biological age is secondary. Demonstrated intellectual maturity is the true, legally binding measure of autonomy. When an adult patient's capacity assessment unequivocally fails, the patient's autonomy is temporarily suspended. The clinician must then pivot to alternate legal pathways to provide care. In immediately life-threatening emergencies, where the patient lacks capacity and no surrogate is present, care proceeds under implied consent. Immediate life-saving interventions are initiated to prevent severe harm or death. In non-emergent situations, paramedics must adhere to the Healthcare Consent and Care Facility Admission Act. This statute dictates the strict legal hierarchy of substitute decision-makers. This flowchart details the procedure for determining who can provide substitute consent. The assessment begins at the highest legal tier. The paramedic must first determine if the patient has a court-appointed personal guardian or a legally designated representative with an active representation agreement. If those specific roles do not exist, the provider relies on a temporary substitute decision-maker. The law requires following a strict statutory order, starting with the patient's spouse, then an adult child, followed by a parent, and continuing down the designated list of relatives and close friends to secure consent. Throughout this process, there is a hard ethical boundary. Paramedics must never intentionally encourage, manipulate, or coerce any patient or their surrogate into refusing care or conveyance. For high-risk refusals where capacity is in question, escalation is mandatory. The clinician must contact Clinicall to speak with an online medical oversight physician who helps assess the legal risks and formulate a safe care plan. Specific clinical triggers require this physician notification before clearing any scene. These include patients in police custody, individuals with an altered level of consciousness, those with head injuries, and patients at extremes of age. When neurophysiology strips a patient of their autonomy, paramedics must rigidly adhere to statutory SDM hierarchies and physician oversight to ensure lawful, ethical care. Moving from the physical scene to the administrative aftermath reveals a harsh reality. In fact, non-transport calls, where a patient refuses care, carry the highest liability risk of any pre-hospital interaction. Because the patient is not conveyed to a hospital, there is no formal transfer of care to a physician. The electronic patient care record stands entirely alone as the definitive medical and legal record of the event. Documentation precision begins with the response outcome field. The clinician must accurately select patient refused care and/or conveyance to legally categorize the call. The narrative requirements are exhaustive. The record must detail the exact risks disclosed to the patient, document the patient's specific rationale for refusing care, and provide concrete proof of their comprehension. Simply charting that a patient is alert and oriented ×4 is completely insufficient to prove capacity. The chart must document the exact steps taken to assess the patient, detailing their speech patterns, behavior, affect, and the specific form and content of their thoughts. The clinician must also develop and document a safe care plan. A physical copy must be left with the patient or their family, detailing warning signs to monitor, recommended self-care, and explicit directions to call 911 or a health advice line if symptoms worsen. Details of any mandatory clinical or physician consultations, along with the contact information for any witnesses present on scene, must be strictly recorded in the final file. In the eyes of the law, if the comprehensive assessment, the disclosure of risks, and the capacity determination are not completely documented, they never happened.